Everybody, welcome here on WJOB. We have a brand new show that we're getting started here on the first and third Mondays with Midwest interventional spine specialists, and we've got Dr. Kondamuri in the studio. It's Doctor, it is a trying time for everybody, and we're going to get to some of that discussion in a little bit. But first, let's talk about yourself. We were talking kind of the cliff notes of your career, and we talked to your son, who we mentioned. If the name sounds familiar, Kondamuri. We talked to his son Nathan a week or so ago about his Shark Tank endeavors. If we have time, we'll get into that as well. But just tell everybody a little bit about yourself.
Sure. My name is Sean Kondamuri. I grew up in the Chicagoland area. I grew up in Schaumburg, Illinois. Did all my training in Chicago. I went to University of Chicago, but then a residency and other advanced training, like my medical school residencies and fellowship, were all on the East Coast. I went to school and finished up my fellowship training in pain management at Yale University in Connecticut, and then I moved out here. We started our practice here in Munster, Indiana, in 1996. So I've been in that practice with my partners since 1996, going on almost 25 years.
You always want to be a doctor?
No, well, actually, originally I wanted to be an astronaut.
Ah, okay. Yeah, That's a lot different, yeah.
A lot different. I remember when Apollo 13 landed on the moon, and Neil Armstrong landed on the moon. And in fact, my oldest son is named Neil after Neil Armstrong. So at that time, I thought I was going to be going to the moon or going to Mars. That's what I thought. And then come middle school, high school, I realized probably more practical to try to be a doctor. I decided to be a doctor.
Yeah. How'd you end up around here in Munster?
So, great question. So when I grew up in the Chicago suburbs, I thought I'd come back to Chicago suburbs, and I came back home after finishing my training and looked and met some different people, looked at opportunities in Chicago, and then I happened to meet one of my partners, Dr. Gupta, here in Indiana. Mm-hmm. He had a facility here in Munster, Indiana, and we spoke on the phone from me on the East Coast here in Indiana, and over the phone we made a deal to just come together and start a pain center. And there was no real pain center going on here. So we started that pain center here in Munster just over that one phone call, and we've been partners ever since.
So you come back here to Munster, and eventually now, as you said, you guys are partners in Midwest Interventional Spine Specialists, right?
That's correct.
All right, so you wrote a book, too, I heard recently, about pain.
Yes.
I've had something, I'm only 27, but I've had some back and little things going on. So I think it's a big thing for a lot of people. We don't probably realize until you go through it how important it is.
Yeah, I mean, chronic pain is something that affects nearly everybody in America. 100 million people suffer from chronic pain in the U.S. every year. And at least 80% of us are going to have pain at some point in our lives, maybe not prolonged pain, but at least some chronic pain that may take you to the doctor. And the majority of that chronic pain is just like you said, Sam, it's back pain. A lot of us have back pain or neck pain, and that is what we specialize in. That's why we're interventional spine specialists. We take care of spinal pain, whether it's the neck, the low back, or the thoracic spine. That's probably 75% of what we do. We take care of a lot of other painful problems, like from arthritis and nerve conditions, but it is primarily spinal pain, because that is what really is the biggest troublemaker out there.
You think a lot of people don't necessarily go to the doctor when they have stuff like that? You think it's a lot of Tylenol, Aleve, and other things of that nature, maybe a little ice, and when they could have something more serious going on?
The majority of people, Sam, don't have anything serious going on. The majority of them should be resting for a day or two, and then after that, getting up and moving around, getting up and exercising. Go see a physical therapist or a chiropractor, but not necessarily going to see your doctor, because most of it is what we call self-limiting, which means that the pain is going to come on and it's going to go away just as fast as it came on, just like in that manner. It'll come and go without you really doing a lot, but taking Tylenol or Advil and exercising. And generally that solves most problems. Now, if people have an injury at work, for example, like if you lifted something heavy and you suddenly felt this horrendous pain in your low back or down your leg, that's something that's a little different, and then you need to seek out some medical care for that probably.
So you guys are in Munster, but you're in Chesterton as well.
Yes, we're in Munster, Chesterton. We're in Hobart and at St. Mary's Hospital, and in Dyer at St. Margaret's Hospital, St. Franciscan.
So of people in Northwest Indiana who are in this area, right, in that Munster, Chesterton area, or really anybody who could maybe go see you guys who's within probably a 20-mile radius, I would bet, do you find that there's more or less of some of the typical issues that will plague folks with the spine around this area?
Yeah, it's pretty much typical issues.
Okay.
I mean, in medicine we have one phrase that if you hear hoofbeats, don't look for zebras, look for horses. Hoofbeats means if you have a common symptom, don't look for rare things. It's typically going to be a common thing, like a common back problem, that such as spinal stenosis or herniated disc or sciatica or arthritis in the joints. So the majority of people here in Northwest Indiana are going to have the same common problems that anybody else would have.
What made you go into this specialty?
Oh, that's a great question. So when I started off in internal medicine, actually.
Mm-hmm.
I was at New York Medical College doing my internal medicine residency, and I thought I was going to, become a cardiologist, actually. I thought that's when I started residency, that's what I thought I was going to do. But then I noticed that a lot of people on our medical floors would have a heart problem, or they'd have lung problems, and they get a lot of attention. You have a heart problem, everybody's running on you, they're doing all kinds of tests on you, they're doing everything they can to take care of you. But then if the patient was complaining of back pain, typically they might get a Tylenol, and nobody would do anything about the back pain. Now this is 20 plus years ago. Nobody really cared about the back pain, and I thought that doesn't seem right, because sometimes the patients are suffering more from their back pain than their cardiac problem. Not that cardiac problems are minimized; you should minimize that, but the back pain is a major issue. So then, just around that time, fellowships were starting in pain medicine. A fellowship meaning an advanced training program that you do after your residency program, which is after medical school. So those fellowships were just starting at that time. And to go into a pain management fellowship program, you needed to go into anesthesia. So when I finished medicine, I did an anesthesia residency so that I could do a pain fellowship in order to practice pain. That's how I ended up in pain.
Did you ever have any issues yourself that maybe prompted that too? Yeah,
I do. I've got my own back problems. In fact, I sometimes tell my patients, Sam, that, I see what you've got on your spine. Here, I'm showing it to you. Then I'll take a picture. I'll show them a picture out of my phone, and I'll show them my back. And I have a very bad arthritic problem at L5S1. It's almost bone on bone. There's not a lot of trouble. There's not a lot of room there for the nerves. And I will get pain into my back and into my leg. Every 6 months or so, I'll have some pretty wicked pain for maybe 5 days or 7 days, and then it's gone. I'll take some ibuprofen, I'll exercise. And I tell my patients, I've never needed to have an injection or surgery. I just exercise. I exercise pretty hardcore, 5 to 7 days a week, do a lot of core work, and I try to avoid some of the things that tend to bring it on. You don't want to lift things the wrong way. You want to use your legs. So you just do all the stuff you're supposed to do, and for the most part, you'll do well. Now, I have the luck and the luck to not have to have it. My job isn't a very physical job. I'm just on my feet all day long, but I'm not lifting something like some of my patients who are iron workers or steel workers. They've got pretty physical jobs, so they're going to be at a little bit more risk for their back. But aside from that, half my patients are office workers. They don't have a lot of physical demands on their back, but yet they have all these problems.
That's something I noticed too, starting here about 4 years ago. Not that I was super active, and I still am kind of. I officiate and coach and do stuff like that, but I had that all of a sudden. Pretty much it kind of was gradual, but it happened in the course of a week or two where all of a sudden I had just sharp pain down the sides of my legs, and it would go back and forth, and it became better though as I did exercise, and that was kind of the prescription. But every once in a while, you can tell where your body lets you know that you're laxing in that effort to exercise, because all of a sudden it will get bad for a couple of days, as you mentioned.
Yeah, and you want to listen to your body. If your body's telling you that something's wrong, you're probably right. The body is giving you a signal, but it doesn't mean you want to rest all day. You don't want to lay in bed for 3 days, 5 days. That's the worst thing you can do. You have to get up. You have to move. And I tell my patients that all the time. What did you coach?
Baseball.
Okay, so baseball is a lot of torsion there.
Exactly.
You're swinging a bat. It's a tremendous. It's like golf. Tremendous torsion on your spine.
There were some times I could not hit infield because it would hurt me that bad.
Sure.
Yeah. Sure. And I'm the 25-year-old, 26-year-old guy at the time, and I'm thinking, what in the hell?
What's the future got for me? Right?
Exactly. Yeah.
What about when I'm in 45?
Oh
and
my
55?
gosh.
Yeah.
One last note on that before we kind of get to the elephant in the room of all the coronavirus stuff. Sleeping. How much? Because I find this. I sleep on my side. I kind of twist myself up a little bit, and I wonder is that an issue?
Yeah, sleeping is an issue, and you're doing the right thing. I tell my patients you should sleep on your side, pillow between your legs. Have a pillow between your legs, and your other pillow for your head should be puffed up enough that your head is sitting on that pillow, but it's not tilted to one side, and the pillow's not too big that your head's tilted to the other side. So your head should be in line. You should be laying on your side. Typically, you do not want to sleep on your back or on your stomach. Now, there are rare patients who that is a good thing to sleep on your back or your stomach, but for the majority of your listeners, sleep on your side. Okay. And don't stay in bed too long. Like if you've slept for 7 hours, you went to sleep at say 10 or 11 o'clock, it's now 7 in the morning, and you feel like hanging around in bed because you're checking your phone and you're checking Facebook or Instagram, get out of bed, because you do not want to be laying on your back, because that's how you're usually looking at your phone.
Right.
for 15 minutes, 20 minutes, or sometimes even an hour or two. It happens. If somebody doesn't have to go to work, they may just lay in bed for an hour, just looking at their phone, and that's the worst thing. You got to get up and move around. Don't be on your back for too long.
Well, I'm going to have to reevaluate some things.
And also, these chairs, you could get some chairs with some back rest. These stools, if you're sitting in that stool all day long,
louder.
We got to let your boss know. Yeah. Get some real chairs here because Sam's back's going to be bothering.
Oh, my God. Dude, there's a couple of times because we'll do the morning show, and it's 2 straight hours of sitting this.
Because then you gotta sit upright and you don't have a support.
Yeah.
So that's the issue.
Well, with everything going on right now, I know everybody's budgets are going to be tight probably.
Yeah.
So
I'll get you a chair. How about that?
All right. Hey, I'm all in. I'm all in for free stuff.
There you go.
Let's talk about what's going on besides spine stuff that you're worried about. Everybody's worried about everything now with coronavirus. Yeah. First, let's start with this. What kind of precautions have you guys been taking for the last couple of months? And did you think, as a doctor, I know this isn't necessarily your specialty, but as a doctor, right, in the medical field, did you think that this was something that would get to this point a few months ago even? No,
we did not. I mean, I think I can speak for many of my colleagues in a sense where I'm almost somewhat embarrassed to say until about a month ago, we really didn't give it any importance. I mean, we didn't think it was that big a deal, mainly because the experts, the government, the CDC wasn't telling us to be doing something overly special to avoid having any risk of transmission of this coronavirus. But somewhere in the middle of February is when I really got serious about it, and I started noticing this is a big deal. And we had a lot of doctors speaking to, finding out from the CDC or speaking to the government about how we need to do a lot more for our patients so we don't have any issues. Because this is very serious. It may be that it won't affect a lot of people, but as Dr. Fauci, from who you see on TV all the time now, has he very clearly said, it is going to get worse before it gets better in the U.S. And even in Indiana, I think we had about 19 or 20 cases as of the weekend. One case being a little closer to us over in LaPorte County. Mm-hmm. I think a patient at Porter Memorial Hospital. And I've heard word that there's a patient nearby us as well that has been diagnosed with coronavirus. I can't say where.
So you see all that stuff going on, and you mentioned the middle of February. Was there a specific event or all of a sudden a feeling? What changed your mind and put the kind of the mechanism in place in your head that said this is more serious?
Yeah, so a lot of things happened at that time, but primarily what was happening in China, we knew about that from December.
Yeah.
But I think we started getting a lot more information out of China in January. We started hearing about other countries being affected, and we started getting a few spattering of cases in the U.S. And there was so much talk so much misinformation, I want to say, on TV, on the cable channels, through the media, that sometimes, as a doctor, you just know what they said doesn't make sense, and then you want to inquire, you want to start looking into it yourself, and that's what really kind of happened. I don't want to point into any specifics exactly.
Right.
But clearly things were happening. And there was just too little importance given to them. I mean, we've been there with H1N1. Mm-hmm. We know about the swine flu. We know about all these other influenza, which happens all the time. We know these things are serious conditions. So if you have another similar virus, we have to take it seriously.
The question I've kind of had this entire time, and maybe you can answer this. I could be setting you up not to know the answer, but
it's okay.
Swine flu, I remember I think I was 8th grade or 9th grade at the time, as maybe a freshman in high school. So I was old enough to kind of know everything that was going on. I don't remember. Now, again, the contagion and the fatality rate is higher for coronavirus, but I think we lost worldwide, wasn't it over 600,000 people died from swine flu, if I remember right?
The swine flu, I think you're talking about, is back in the 1918, 1920.
Well, we had the H1N1.
H1N1, that was probably what happened back when you were in middle school.
Right, but that wasn't that the swine flu thing?
Similar.
Didn't they call it that? I think. Okay.
Similar, but we refer to that as H1N1.
Okay, we'll call it H1N1. How come there wasn't as much concern or shutting down anything? I mean, everything kind of just went on normal with H1N1, and now, I mean, everything's shut down pretty much. We're almost to that.
Yeah, absolutely right. I mean, everything's pretty much shut down now. Back then, the biggest thing is we didn't have media. The media didn't make this a big deal. So believe me, doctors who were in emergency rooms and on medical force were working day and night. Doctors and nurses were working day and night dealing with H1N1 patients because they did get sick, just like our older patients now are getting sick and being taken into intensive care units and being put on ventilators. That was happening then too. You just didn't hear a lot about it.
Right.
The gravity of what's happening now is that this could be much more severe. And that you've probably heard that term, flattening the curve. So if you look at that curve you see on the internet or on TV, you have one graph that kind of goes like this, and that's if you have a lot of cases early on and they all peak at once. Flattening the curve is you start here, and then now instead of going up like this, you go down like this. So it's a flatter curve.
More like a little hill as opposed to a mountain.
Perfect,
right?
like a hill as opposed to a mountain. The idea there is if we can spread the cases out and still have the same number of cases, but spread them out, then our health care system can handle them. Because if we have that big peak, the mountain,
Too much at once.
we don't have the intensive care units, we don't have the ventilators, we don't have the beds to handle those patients. If our area were to get 100 patients, just 100 patients in Northwest Indiana that required intensive care units and ventilators, don't forget we have a lot of other patients that have needs, right? I mean, trauma patients or cardiac or other patients. Where would these patients be handled? It would be a disaster. Yeah,
somebody made the point, I heard, that if you add this on top, if it was just the coronavirus stuff, they could probably handle it. But then all of a sudden you start to think about I don't know what the number is. They gave, I think it was a few thousand, maybe 10 even, of people who break their leg every day countrywide. Do you know what that number is?
I don't know.
Yeah, I think they might have said, I'll just make up, say 10,000.
Okay.
And then all of a sudden you won't be able to set their broken legs because you're so concerned and overwhelmed.
Yeah. Well, so actually a little bit of that's happening right now, Sam. Just over the weekend, Community Hospital and the Franciscan System sent out emails to all of us doctors. The majority of what I do are elective procedures, so pain, as bad as it is, these are not emergency cases.
Right.
Most of them anyway. Some of them are. But if you have pain, that's considered an elective case. And those cases, those treatments or surgeries or procedures that I would do have been put on hold. Mm-hmm. So these two hospitals in our area have sent out a mass email to everyone telling us that we should postpone elective surgery because they want to have the resources available and the beds available to handle the coronavirus or COVID-19 cases should it come up.
Right. The governor said that today too.
Yeah.
Yeah. He put that out, and it's gotten to the point where I've gotten to this point where I was a person who was, I think, for some of the reasons you've stated, and I want to get back to some of the things you've stated and really get a clarification. But I've been skeptical a little bit on some of it because, again, I'm 14, 15 years old, and we had this huge, what felt like an epidemic at H1N1, right? And nobody really did anything. It was just business as usual. Yeah. And so I've always said, well, how come we didn't do it there? And I'm trying to compare the two. But so let's go back to that for a second. What is the difference besides they're saying coronavirus has a higher fatality rate, right? I think it's like 3.2 or 3.4%, somewhere I'm seeing around there.
Honestly, it's really anywhere from 1% to 4% because we're saying 3 to 4% because that's what the numerator and the denominator calculate out to be. But you got to remember, we haven't tested enough people in America. We've hardly done any tests. Really, it just started in the last 1 week. So as you start doing more tests, you're going to find out that a lot of people have coronavirus. Mm-hmm. So if you have, I'm going to throw a number out there, if 100,000 people have coronavirus, now the denominator is a big number, and then you divide that by the numerator, it's going to come down to 1%. Or
you think it'll go down, or do you think it'll go up?
Nobody knows. There's a lot of uncertainty. I hope it will go down because if you look at what happened in the Korean experience, they've tested 250,000 people or more because they've been testing since January. And of all those tests of patients, I think the number is something like 96% were negative.
Right.
So there's a lot of people who have symptoms, but they're not even positive for coronavirus.
Right.
So it's going to be a big number, but a percentage, I hope it's way less than 4%.
Yeah, that's some of the stuff we saw before they canceled all the basketball.
Yeah.
I was watching Indiana play. I've said this on the air a couple of times. They played Nebraska on Tuesday, and Fred Hoiberg, who used to coach the Bulls, people might know him from there. He coaches Nebraska now, and he should not have been coaching the game last Tuesday night. He was very sick.
Oh boy!
And I mean, he was to the point where he's like he ended up having influenza A.
Okay.
Yeah, which is, in all seriousness, and correct me if I'm wrong, some people say that's probably, depending on your underlying conditions and your age, but that could be more serious than even some of the coronavirus symptoms.
So you asked a question a little early, and I don't think I answered it completely, but this is a perfect place for me to say it. You said, what's the difference between influenza and coronavirus?
Yeah.
So influenza is if you have the flu, you're completely beaten down. You have no energy. You can't even get up out of bed to go to work. It really knocks you down. What happens there is influenza cripples your immune system. So your immune system now has just really been destroyed. A bomb is just thrown into your immune system, and it doesn't want to work anymore, and it just shuts everything down. That's not what happens in coronavirus. In coronavirus, what happens is the virus attacks the type 2 pneumocyte, it's called. The type 2 pneumocyte cell is a cell that makes something called surfactant. And surfactant is something that is used in the lungs. And if you don't have surfactant, your lungs are not going to work well, and you're going to get a pretty massive lung disease. And that lung disease is something called ARDS, acute respiratory distress syndrome, and that requires ventilation with an intubate. They have to put a breathing tube down your throat. They have to connect you to a ventilator, and they have to ventilate you to keep you alive. And then there really aren't even a lot of medications to give people. It's more supportive care. So it's a different sort of syndrome. The symptoms are entirely different. I should probably mention the symptoms so people know.
Yes.
For coronavirus, the big symptoms are a cough, a dry cough, a fever, a sore throat, and ultimately shortness of breath. If you have mild shortness of breath, it's not something you run to the hospital for, but if you have severe shortness of breath, somewhat worse than, you literally can't walk across the room when you normally would because you're breathing so hard, you need to call your doctor. And the doctor will tell you, will listen to your symptoms, and he'll say, well, really, okay, it's just mild. Just stay at home, isolate yourself so that other people don't get your illness. If it's very severe, then go to the emergency room or go to the hospital. But we don't want to overload the hospital with patients who have mild disease, because mild symptoms, you can just handle that at home.
Right.
Take Tylenol, fluids, and rest, and you're going to be fine.
Let's end on this. What are you guys doing for your patients? And as you see some of the stuff coming out from, and I'm sure there's going to be more, we think there is, the governor's going to have, which will carry for some of the folks who might be watching this now, at 1:30 he's going to speak. President Trump, I'm sure, will speak here soon as well. And we've heard some whispers and rumors that maybe it'll be kind of a mass shutdown of really all the bars and restaurants, and anything that's maybe grocery stores, maybe pharmacies and things like that might stay open, kind of the essential things.
Right.
Is that something, first of all, your patients, what you guys are doing, and is that something that you think needs to be done? So
we're doing, and I'll tell you, in our office, we're taking this very seriously. We're instituting a lot of precautions. For example, of course, we're washing our hands between patients. Of course, we're using hand sanitizer at other times. We're keeping distance between the patients. This is about max how close we should be, beyond 3 feet apart. That's social distancing. So with that in mind, in our waiting room, for example, we've removed half our chairs. Half the chairs in the waiting room are removed. So now there's no chair in between. We only allow, say, 6 to 10 people in the waiting room so that everybody is spread out. Family members are not allowed to come in with the patient unless they have to come in to assist the patient. Otherwise, we want the family member to sit out in the car. Less people here, less exposure for people. And then when they get into the exam room, similarly, the doctor or the nurse practitioner or the medical assistant is working on the computer here. The patient is 2 chairs away. So when I come in and see the patient, I'm keeping my distance. I'm not even really elbow tapping anymore. I did that last week. This week it's more, hi, how are you? It's just, a verbal greeting. So if we maintain all the social distancing, we clean all our surfaces, make sure there's very little risk of transmission of the disease. By doing these measures, we're very safe. Regarding closing the restaurants and bars, I hate to say it, but in Illinois, when Governor Pritzker shut the bars and restaurants down over the weekend, I think the impetus for that was St. Patrick's Day. On St. Patrick's Day on Saturday, the bars were packed. And there's no social distancing going on there.
No.
So people are getting the illness from each other, and they're potentially taking it back home. And to whom at home? We're talking about taking it to your grandparents, to your parents and grandparents. If they're 80 years and above, 80 years old, they're at high risk of getting ill. And that illness could literally kill them. It can be a very serious illness. And we're talking about anybody who's over 80, over 70 even, who have heart disease, who have lung disease, who have diabetes, hypertension, cancer, anything that weakens your immune system. Those patients are at high risk. And age itself weakens your immune system. That's why we say anybody who's 70 or 80 is at risk. So, yes, precautions have to be taken. And, yes, I agree. If our governor says we've got to shut things down, I would tend to believe what they say, because it's coming from the CDC. It's coming from Dr. Fauci. They are making decisions that are, this is public health. I mean, I may have my own opinion about how to treat patients, and I'm allowed to do that, but I have to listen to the public health gurus, because we don't want to spread a disease. It could be serious. It may not be, but it could be.
Doctor, thank you so much.
Thank you very much, Sam.
All right.
And we'll do this.
Yeah, there you go. All right. First and third Mondays, you can expect to see these folks from the Midwest interventional spine specialist, and we'll see you every time, right? Or
yes, probably me most of the time, or maybe my partners.
All right. We'll look forward to it, and we will see you in a few weeks. Hopefully, we've got some good news to tell the folks.
I hope so.
And update. Hopefully, we're down the downturn, right?
I hope so.
Yes. All right.
Yes.
Until then, this has been the Midwest Interventional Spine Specialist for Dr. Sean Kondamuri. I'm